Good morning. We're calling our third meeting of the Medicaid Oversight and Advisory Committee meeting to order. Before we get into our formal agenda, I'd like to take a moment just to remember those folks in Eastern Kentucky who have lost their lives. So if you would, please join with me in a moment of silent prayer for those folks. Thank you. And we certainly wish and pray for the continued recovery of our communities in Eastern Kentucky. Devastating times. First order of business, approval of minutes of the July 7th, 2022 meeting. Is there a motion to approve?
So moved.
Motion by Senator Alvarado, seconded by our co-chair. All those in favor say aye.
Aye.
All opposed, no. Motion carried. Roll call, please. Sorry, I got ahead of myself.
Senator Alvarado.
Here.
Senator Carroll.
Here.
Senator Higdon. Senator McGarvey. Representative Gooch. Representative Gibbons-Prunty. Representative Sheldon. Representative Wilner.
Here.
Co-chair Meredith.
Present.
Co-chair Elliott.
Present.
Also, we do have a quorum. Our first item on the agenda is the impact of federally mandated staffing ratios for nursing facilities, and we have Betsy Johnson here to testify on behalf. If you would, please come forward. You know, Ms. Johnson, I'm always reminded of the first lesson I learned when I came to the Senate in 2017. A good friend, Senator Steve West, and he told me, you know, every legislation we pass has unintended consequences, and that certainly is true. And that's one of the reasons I want you to hear today, because you know I think that certainly there's good intent behind these mandated staffing ratios, but we don't stop to really understand the impact it could potentially have on our citizens and our providers. So welcome you. If you would identify yourself for the record and feel free to proceed.
Thank you, Chairman Meredith. I think you stole my main line, so thank you. Again, my name is Betsy Johnson. I'm the president of the Kentucky Association of Healthcare Facilities. We represent skilled nursing facilities, personal care communities, and assisted living communities across the Commonwealth. With me is Emily Weber. She's our communications director, and she will tell me if I'm saying something wrong. It's always an honor to come before this committee, and especially to talk about something as important as President Biden's proposal for minimum staff ratio mandates in skilled nursing facilities. Slide 2. Okay, there's a lot of words on the slide, so I'm going to try to go through it to make sense of it. We try to make it as simple as possible, but this is complicated information. In April of 22, the Centers for Medicare and Medicaid Services released the proposed Medicare payment rule. One of the proposals in the rule was to reduce Medicare payments to skilled nursing facilities by $320 million. CMS sought comments on this proposed cut, and nursing facilities across the country submitted over 4,000 comments to the proposed rule. In late July, CMS issued the final rule for the nursing facility prospective payment system, and it resulted in a 2.7% increase. There were a lot of pluses and minuses. People smarter than me did the calculations, but in the end, CMS listened to skilled nursing facilities and realized that because of increased costs, not only in supplies, but staff costs, that a 2.7% increase in Medicare payments was warranted. The proposed rule included a request for information seeking input on establishing minimum staffing requirements for long-term care facilities. Again, thousands of comments were submitted on the proposed minimum staffing requirements, and CMS acknowledged that they were continuing to review those comments. CMS stated that based on the comments that they have reviewed, many individuals commented on the overall approach for establishing these staffing standards, recommendations for implementing a minimum staffing requirement, and factors that should be considered, such as payment, cost, and barriers, and input on forthcoming staffing studies. We're going to focus on the issues such as payment, cost, and barriers, which are very important to implementing any new regulatory requirement. Additionally, CMS will be conducting on-site visits between August and October of this year in skilled nursing facilities. 50 site visits in a mix of states from all regions from mid-August to end of October will happen, and 25 site visits from January to March of 2023 to happen. President Biden has made it very clear that he wants to implement this within a year, so they're seeking information currently. So there's a lot we don't know yet because CMS is still studying this issue. However, on the next slide, I will address what our best estimates of the impact on the minimum staffing requirements will be. But today we do know that, that federal regulations require that total nursing staff hours per patient day so licensed nursing services require 24 hours a day with a registered nurse on staff for at least 8 consecutive hours a day, 7 days a week. This equates to 0.30 staffing hours per resident day. So again, there are already minimum standards within federal law. Kentucky reported 3.78 total nursing staff hours, which included registered nurses, licensed practical nurses, and nurse aides per patient day from the Nursing Home Compare website as of June 30th, 2022. CMS calculates the total by taking the total nursing hours reported by the Kentucky facilities by the total patient days with those facilities to yield total nursing staff hours per patient day. So again, you will see that Kentucky staffing hours from June 30th, 2022 is a total of 3.78, which is above the national average. In that number, it includes 0.74 hours per patient day for our registered nurses, 0.87 per patient day for licensed practical nurses, and 2.17 hours per patient day for nurse aides. Again, the federal regulations require 0.30 for licensed nurses, so even when you break that 3.78 out, we're above the national minimum standards. If the federal minimum staffing requirements determined to be 4.1 hours, which is what they're discussing per patient day, nursing facilities across the country will have to hire 187,000 nurses and nurse aides, and is estimated to cost providers total across the country nearly $10.1 billion. A recent survey was done of skilled nursing facilities, and responses show that 98% of skilled nursing facilities are experiencing difficulty hiring staff. So our next question becomes, where are the people? And this goes to, we talked about costs, but now we're going to talk about the barriers to hiring these individuals. And I'm always honored to come before this committee and share the stories of my members. However, I firmly believe it's much more impactful if you can hear directly from the members that we serve. We will now play a short video where you'll hear from Karen Venus with Sayre Christian Village in Lexington, Kentucky, and David McKenzie with the Jordan Center in Louisa.
So for us as a nonprofit, when we talk about minimum staffing, it is a concern, most importantly, because we are, just like any other long-term care facility right now, we're struggling to find staff as it is today. Our challenge, obviously, is the increase in wages and just the numerical number of folks that have, and those folks are not being replaced with new folks entering the industry. So for us, the concern is, where are the people going to come from? I think for our team, it's just going to add another layer of pressure that already exists. I mean, next to a nuclear power plant, we're one of the most heavily regulated industries out there. And so we are constantly on our game, making sure that we're on top of any new regulations that are coming. You know, obviously we will rebound, and we will, if there is a minimum staffing requirement, we will adhere to that. It is concerning because it's one more thing, one more metric that we will have to focus on. And again, for us, the biggest concern is where are these individuals going to come from? Our industry has lost so many folks. They've from the pandemic. We were beat up, and the war that we fought in long-term care, and it's still not over during this pandemic, in my mind, is unlike many other environments out there. And so I believe that COVID fatigue is real. Again, it's going to be, where are these people going to come from, and how are we going to have the resources to pay them? Because if there's going to be a staffing mandate, we're going to have help from somebody to funnel us a workforce. We're depleted. The pipeline is depleted, and I'm all about a minimum staffing ratio. If that's what if that's a regulation that we have to follow, of course we're going to follow it, just like we do all the other regulations in this industry. However, we can't do it in the current environment. The people aren't there. So we've got to have the people in that pipeline in order to meet this minimum, or we're all going to fail.
My name is David McKenzie. I am the owner and the administrator of the Jordan Center in Louisa, Kentucky. And I've been here for 23 years. Prior to that, my father ran the facility for 26 years. We started this company in 1974, and there have been 2 administrators. The only way I'm able to keep staff, and by the way, I've had to close half of my building, so I'm a 110-bed facility, but I'm only able to staff for 60 patients. And the only way to keep those ratios is I had to increase my cost of labor by 48% this year. That's just since the month of February. That's when we instituted across-the-board wage increases, as well as some other retention things. It wasn't strictly wages, but it was mostly wages. And I am averaging $118,000 net loss each and every month of this year. If we don't get some help within months, we're going to go out of business. And we've been in this community since 1974. You know, we're going to lose it. I don't know how to express to you how hurtful it is to think about not working here anymore and this place not existing. It's more than a job, and it's more than a career. It's part of my DNA now.
So on slide 5, I think this graph is pretty straightforward. You will see from February 2020 to the most recent data available, nursing facilities have lost 4,347 jobs during the pandemic. Although this week, the Bureau of Labor Statistics reported that nursing homes were seeing an estimated 3,700 jump in new hires nationally, the sector has seen the loss of nearly 229,000 caregivers, or more than 14% of the workforce since February 2020. Based on the current numbers, the model indicates workforce levels may not return to pre-pandemic staffing levels until 2026. And remember, President Biden's goal is to implement these minimums within a year. 4 years is a long time to wait. Our people are worn out, they're exhausted. I think you probably sensed that from both Karen and David's videos. On slide 6, you'll see that all sectors of senior services, and these are Kentucky-specific numbers, which includes AL, PC, and skilled nursing facilities. The graph from January 2020, and this is based on a quarter basis, so we do attribute this to COVID. Those numbers have dropped significantly too, and so across all senior services in Kentucky, we're down 5,505 jobs. So then the next slide, again, it's pretty self-explanatory. We work closely with our healthcare partners, the Hospital Association, and other groups on workforce issues, but you'll see in the slides, skilled nursing facilities have been the most significantly impacted by workforce shortages, and we have yet to recover as other areas of our healthcare sector have. And so, what can we do, and how has this impacted us? As David McKenzie explained, when you have limited staff, in order to ensure quality within your building, you're going to have to close down some beds, which of course causes backlog in our hospitals because they can't discharge people timely to the skilled nursing facilities. And, you have to limit admissions, and that means for lower revenues coming into the building, as David McKenzie explained so well. Our staff and providers are facing burnout, mental health issues, post-traumatic stress disorder from COVID. People are retiring like I've never seen before. People that have been with our association for years, our leaders, are leaving. Child care has always been a struggle and continues to be a struggle. We have transportation challenges in both rural and urban settings. And of course, we compete with non-healthcare sectors that can pay more because we are so dependent on Medicaid for reimbursement. And what we need, so again, these are issues I know that the General Assembly has talked about in recent years, and our association is always happy to continue those conversations. But a loan forgiveness program such as was passed last session, tax credits, affordable housing, child care assistance, mental health assistance, easier pipelines into long-term care professions, and of course, again, we will be talking to Medicaid about our Medicaid rate to ensure that it reflects the current environment with regard to staff and supply cost.
Thank you, Betsy. It's always very informative and a little bit depressing,
Yeah.
too. I've always appreciated the challenges of your industry, and quite truthfully, I don't think that we've ever given, the general public's ever given the respect that the industry should have. You do a tremendous job, and folks who have been in the business a long time, they truly are angels walking on the face of the earth. I was glad to hear in your first video presentation that there is support for minimum staffing requirements. I think something we all support. I guess in theory, the idea staffing ratio would be 1-to-1, but we know that that's not realistic, right. And very proud to see that your industry standard is higher than the national average.
Yes.
But do you have some idea of what an ideal staffing ratio should be? Is 3.7 adequate, or is 4.1 really where we should be?
And that's an excellent question. I don't have a magic number, and I do think it depends on the facility or the community. And based on census, I mean, I'm always concerned when the government does a one-size-fits-all type of regulation, because for those of you who have ever been in a skilled nursing facility, I know Dr. Alvarado has, it differs, and it's complex, and based on acuity of the resident, based on the size and shape of the building. And I always say, I mean, I've been in a lot of skilled nursing facilities in Kentucky. And once you've been in one, you've been in one, because they're laid out differently. The workforce is different. So I'm not sure that there's a magic number. And you're right. You heard that from Karen, because Karen runs a fantastic community in Sayre. They're always going to be striving to comply to the highest degree with any regulatory oversight. But and we're not going to ever say that regulation is bad. It's just that there has to be support with that, whether that's financial support or some solutions to open up the workforce pipeline to bring people into skilled nursing facilities, because it's not from lack of trying. I mean, we had a presentation recently where we talked about the costs that have gone for geofencing and advertising and retention bonuses, and I mean, Emily sits on the Chamber's talent pipeline. She meets with them almost weekly. And we're having these discussions. It's just a matter of finding those people who want to enter into the workforce.
Well, it's fun and interesting. These federal mandates are almost always immediate,
Yeah.
and that's truly is problematic.
Yeah.
The reason I asked the previous question is kind of a leading was, maybe as legislators and industry leaders, we need to talk about what that ideal staffing ratio is and develop like a 5-year plan as to how do we get there, rather than just throw it out there, because all the issues you've identified certainly are real and there are challenges. I think we all want to improve the quality of care in all of our facilities, and this is one way to do it, but we have to do it as a partnership. So that's something I think we need to have continued dialogue on. But with that, Senator Carroll, you have a question?
Thank you, Mr. Chairman, and Betsy, thank you all for the presentation. And just a quick comment and then a question. I think it's important to remember also that the effects that our long-term care facilities are feeling and their reaction having to increase pay, there's a trickle-down effect to that to other types of providers. It's running day programs. We have had to increase our pay for CNAs tremendously. We were about to lose our CNAs to long-term care facilities because they have increased their pay so much to keep staff. And for us to stay open, I had to do the same. So it's not just that industry that this affects. There are other types that are related that this impacts also. So I would ask that we also think about those things as we move forward. My question is, have you all been able to conduct any type of studies on your staffing to determine pre-COVID with the staff that left, who are they and where are they? Was most of it due to retirements? Was it moving into other healthcare areas, hospitals? Do you all have any data on that? Are you actively pursuing that?
And actually, Emily did a survey during COVID, and we're actually putting a new survey out, but maybe I'll have her speak to what she found with that.
Yes, so we have done a few surveys based on
Excuse me. Again, would you introduce yourself for the record,
Sorry,
please?
yes. My name's Emily Weber. I'm the Director of Communications for KHCF.
Thank you, Ms. Weber.
We have done a few surveys to our members based on their workforce shortages prior to COVID, in the midst of COVID, and then we are currently in the process of getting one out now to see what their workforce shortages look like. And we have seen many different factors, those that you have mentioned, that that there are retirements from long-term care, but also they're moving away from the healthcare industry overall. There are remote jobs available. There are new opportunities, and they just have felt so burnt out that they have decided to pursue other options. There are also the COVID stress and burnout, child care issues. Trying to think of all the different factors.
And transportation.
Transportation.
But Emily's right. I mean, it was the 2 years that we were dealing with it in the part of the time of the lockdown. There's a breaking point for healthcare workers. I mean, we're seeing it in other sectors away too. But I think what I would like the committee to realize is that skilled nursing facilities were very unique, is because we truly were locked down. So the staff not only were the caregivers, but they took on the family role too, because the family was not able to enter the building, and not because the skilled nursing facility made that choice, but because the government did. And not that it wasn't the right choice, but it caused a ripple effect of stress and post-traumatic stress disorder. And at certain points during COVID, skilled nursing facilities had the most significant loss of life, and we also lost a lot of healthcare workers during that time. So I hope that answers your question, but I also, Senator Carroll, if you don't mind, I understand your struggles, because healthcare unfortunately becomes there's a tiered to it, and hospitals can always pay more than we can, and it sounds like we possibly can pay more than a day center. So that causes inequities in the system, and it's usually based on reimbursement models. because, of course, hospitals can receive commercial insurance, which pays more than what we receive in Medicaid.
Good point. I think that's an excellent point. Mr. Chairman, may I follow up just one quick?
Yes, briefly, please.
The child care issue, I would challenge your association to start thinking about within the industry the possibilities of building or including child care facilities as part of the long-term care facility. And I've heard people talk about this before, but what a great model to have kids there on site to spend time with the seniors. And as we move through, and we have the task force now for early childhood education in the state, and I would ask you all to think about that, and we may ask you to come present before that task force completes. And I think all business and industry within the Commonwealth needs to start thinking along those lines about providing on-site child care. And then we as a state need to be thinking about the regulations on how we can adjust regulations to make those things happen to solve some of these problems. So please challenge you to start thinking along those lines and maybe pull together some information from some of your centers to see what those barriers would be. That would improve the quality of life for the kids and for the seniors to be right there.
And I agree with you. And during COVID, when they shut down the daycares, we were having those conversations with the cabinet. But can we send the just limited to the staff to centers on the campus of the facility? And those were interesting conversations, but they need to continue as well.
It would take some regulatory changes because with the different age groups and trying to keep separate. But it's something we can look at. We're trying to just open the book up on child care and rewrite it to make it fit where we are and allow us to move forward as a state.
Right.
Thank you, Mr. Chairman.
Thank you, Senator. Senator Alvarado, and then we'll finish with Representative Wilner. So, please.
Thank you, Mr. Chairman. So obviously I live this every day. I'll be later on seeing patients later on today. So this is a real issue. I don't think, a lot of our medical providers in hospitals don't spend any time in nursing homes, often have no idea. They think that they operate like a hospital would, and the same rules apply as in a hospital. And it's much stricter in a nursing home as far as rules for providing care for folks. People think you can regulate somebody's diet, and you can't. It's like an apartment. They can eat whatever they want. So I'll have a patient in a hospital with heart failure. They have 30 pounds of fluid removed. As they're being wheeled in, order me a pizza. And you're like, that's just going to put the fluid back up. Well, I can't restrict them. If I do, I am abusing that patient. In a hospital setting, they can say, nope, you're going to follow the rules here, and if we'll kick you out against medical advice, and they have that ability. But in a nursing home, you don't. Lots of rules, and the volumes are much heavier than any kind of hospital regulation would be, or any other medical regulation would be. And I think people don't fully understand how deep that is. I've often said, if you want to get the attention of the medical community, attention of legislators, is for a bunch of nursing homes to lock arms and say, you know what, we can't take any new patients for a while, 2 or 3 months, and see what happens to the healthcare system in the state of Kentucky, or in the country for that matter, because our hospitals would back up with patients, have nowhere to send them. Families would be out crying saying, I can't take care of mom or dad. They're too sick. I can't handle it. I got to go work. I got to have them go somewhere. Well, we have no room. You know why? Because we've imposed nursing regulations, and I got to have a certain ratio. I've had to shut down a bunch of beds. If that happened, everyone here would wake up and say, we got a major problem on our hands. We got to do something. All we're doing is kind of just riding along. We hear these reports. Everybody says, oh, yeah, there's a problem with shortage of but we live it. I live it. I see it every day. And it's coming very, very soon, where you're going to have facilities that are major employers in our communities that don't, a lot of those folks will be suddenly unemployed. All these folks have to be shifted somewhere else. Many counties, out of state perhaps, to some other place, because we have nowhere close by for them to be closer to their families. Nursing, the ratios, it sounds great. It's something that legislators can say, I'm going to hang my hat on that. We got something done. We fixed something. You can say everybody's got to have 10 pink flamingos or green flamingos in their front yard. We can't find any. Well, you got to have them, or you got to shut down. You're going to just shut places down is what you're going to do. So we can impose these and say you're going to find them as though these are people we can just pump out of a gumball machine. You can't. These are individuals who choose where they want to work, and if they don't want to work in that setting, we can't force them to work in the setting. And frankly, we know there's a massive nursing shortage. States like California have imposed this, and I know the nursing associations here have come out later saying this was a bad move. a mistake. You shouldn't have done it. And somewhere along the way, as government, we just don't trust the people that provide the care in this field to do the right thing. And that's how I view it. That's how so much of healthcare is anymore, is that, are we seeing these kind of did the federal government come in and put these regulations in place for hospitals to say you have to have this regulation? I don't know that they did. I don't think they did it for a doctor's clinic or for anyone else, but it's the nursing homes, because you all are, that's like we're intent on abusing these individuals or something. And that's the perspective that people have. And they don't understand that if you went in there and spent some time in a nursing home with the nurses that are there, that these are the people that hold these folks' hands as they spend their last minutes of life, that they become family for us and for the people that are there. And somehow there's like, no, you're there to hurt family, to hurt people. And that's the perception from government, from federal and from state and from everybody down the chain, that we're somehow there to hurt people. And that's what's offensive. And you talk about burnout, that adds to the burnout. Because when you're providing that care and that becomes your life, that from 12 hours, I mean, there's assistant DONs there who are doing the director of nursing work, and now we're having to do so all day long. They're director of nursing, overseeing the daytime nurses, and there's no one to do the night shift. They work night shift all night. And then on morning, they come back on, and they're working all day again to oversee. They're doing 36, 48-hour shifts in a row to provide the care because there's no one else to provide it, and they frankly care about the people in those beds. And when we're saying, you're not doing a good enough job, you need to just find more people to do it, there's no one else out there, folks. I mean, that's the reality of what we're facing. And until these facilities have to shut down, I fear that we're not going to pay attention and no one's going to notice, because the warnings have been coming for a long time. And it's about to hit the fan, unfortunately. So I know it's not just the money. I mean, because they just bring us more dough. Again, there's no one to hire for these roles. And I often say I think it's a lack of trust for the people that provide the care, because they think that somehow we have a nefarious purpose to hurt the people that are there, and we just frankly do not. I'd invite any of you to spend 24 hours in a nursing home and see the care that's provided. Often what the staff have to go through. I mean, I know nurses who were hit by someone, had their jaw broken, had it fused, and as soon as they come back to provide that same individual who broke their jaw the care that they provided. Right. So I go on a rant, Mr. Chairman, and I'm sorry for that, but this is very personal. I know I've had discussions with reporters about this topic a few years ago, a really irresponsible and lazy reporter, frankly, who wanted to talk about this, and I gave him the reasons why I think this is probably not a good idea. And the report was more about the nursing homes that I worked at and their rankings, and he wasn't even concerned about the topic at hand. But this has been a discussion that I've been willing to talk with anybody about, to trust the people that are out there to do the right thing. I mean, we want to have as many nurses as possible, provide as much care. It's a true struggle. It's been a struggle for a long time. The more regs you put on, the harder it is. A veterans nursing home, I think of the one in Wilmore, Thompson Hood, they have lots of beds that are laying empty. Why? Because federal regulations apply to them. Yep. And they can't find the nurses, and so they just, veterans lie in hospitals, the VA looking for a place to go, have nowhere to go because we can't provide the nurses because of the ratio issues that we have at those at that facility. Thank you, Mr. Chairman. I appreciate the ability to rant.
And Chairman Meredith, can I make we pray for the flood victims. Letcher Manor, which had to evacuate because of the flood. We heard from their regional vice president, and she said that to Dr. Alvarado's point, who these caregivers are. So these are people who lost their homes or cars and some family members, but they were in the facility taking care of, making sure those elders were safely evacuated and then help with them back. So, these are unique individuals.
That they are. And Senator Alvarado, I appreciate your comments on that. And 7 years that I've known you, I've never heard you go on a rant before. But, Representative Wilner, you have the last comment on this.
Thank you, Mr. Chairman, and thank you for the presentation. It's overwhelming and it's daunting, the challenges we're facing. And I hear so often about the healthcare force dwindling because people are leaving. And I get my question, it does nothing to address the immediate problem, but I wonder if having lower staffing ratios would ultimately help with staff retention. If people have lower caseloads, if they're able to provide more one-on-one, if they're able to have those relationships with the patients and, when nursing homes aren't shut down, with the family members. And if there's any data to show that these lower ratios actually can help again, not for the short term, but with the long term of staff retention.
And I agree with you, Representative. You know, if you saw the chart, we're mostly nurse aid dependent. We have LPNs, we have RNs, but most of the caregivers, direct caregivers, are nurse aides. And I'm sure it's very stressful when they have several call lights going on and they can't get to the residents in time. Because as Dr. Alvarado pointed out, these people are there because they want to be there, right? So if you're going to show up to work every day, you're going to want to do a good job. And if you can't, because there are not enough people, it's going to cause stress, it's going to cause burnout. I mean, all of us in all of our jobs, if we have too much on our plate, we're going to get burned out. And that's true, but that goes back to the question, where are the people, though? I mean, if you, I would like to work with the General Assembly about opening up the pipeline. I know Representative Moser is very passionate about this. You know, look at how we train our nurse aides. Look at how we have them tested. I mean, we work closely with KCTCS because in some, unfortunately, counties, it's just not readily available to have testing done, and so people are getting backlogged. And these are people who want to get a job, and they thought, okay, this is where I want to be. But if there's one barrier after another barrier, they're going to go elsewhere because there's jobs that are easier to get to. I mean, we have to have background checks. You have to be tested for competency, and you can unfortunately go work at a fast food restaurant a lot easier. But we need people who want to care for people. So I agree with what you're saying. In a perfect world, like Senator Meredith said, we would have one-on-one. I mean, that would be perfect. But you got to pay for that, and you have to have the people to show up to do that.
Appreciate your presentation as always, and we've limited this predominantly to talking about staffing, which I know makes 75-80% of your expense, but I assume you're feeling great financial pressures because of the increase in inflation
Yes.
over the last few months. And we don't have time to discuss this morning, but I would encourage you possibly to share that information with committee members as well as how that's impacting. I imagine the food budgets have just gone out the wazoo, but we'll be curious how that's impacting you as well. But appreciate your attendance this morning, your testimony. It's always very educational for us, and know that you have our support.
Thank you for having us. Thank you.
Next on our agenda is the Medicaid Managed Care Organizations. This will be our third presentation from one of the groups, and this morning we have representatives from United Healthcare. And I'd ask them to come forward and make sure the green light is on your microphones. If you would, please introduce yourself for the record.
Thank you, Chairman Meredith, and thank you, Chairman Elliott, for inviting us and members of the committee for having us here this morning to discuss how we manage our Medicaid population in the Commonwealth. I'm Krista Brindley-Hensel. I'm the CEO for United Healthcare's Medicaid plan here in Kentucky, and joining me this morning at the table are Dr. Cook to speak to our behavioral health and our Chief Operating Officer, Mr. Greg Irby. I also want to thank many of you for making time to meet with me individually before the meeting. I'd be lying if I didn't say I was a little bit anxious for this morning's conversation, and being able to look at some friendly faces across the way hopefully reduces that a little bit. So thank you for taking the time to really provide direction for what you wanted to hear about this morning. Things you may or may not have been hearing about from a United Healthcare perspective really helped us feel more prepared. I also want to say that it's an honor to be on this morning's agenda. I want to recognize that it's National Health Center Week, and just after me on this agenda is Molly Lewis and some members of her team from KPCA. They've been wonderful partners for us at United Healthcare. In fact, they serve many of our patients throughout the Commonwealth. I know they've been incredibly busy, especially in Eastern Kentucky with the community health centers and FQs in that part of the state, but throughout the state. And it's been an ongoing great partnership. So Molly, to you and your team, much gratitude, and I hope you're finding ways to celebrate everyone this week and also recognize what's the ongoing tragedy in Eastern Kentucky. As a state partner, we're assisting to provide some resources out there. I will tell you, our clinical teams that have had relationships relationships, case management relationships with members in that part of the state, immediately went into action, trying to call their members. As we all know, cell phone signals were really challenging, and getting a hold of those people was very challenging. Again, much gratitude to KPCA for lending some support and helping us track down and make sure members were safe, had the medications and the durable medical equipment, et cetera, that they need. In addition, if you haven't seen it yet, United Healthcare was able to donate over $200,000 to various flood relief efforts, including some urgent food boxes of non-perishable foods, ready-to-eat foods at some of the local schools. But that's not what you asked me to talk about today, so I will get right into responding to several of your questions. These should look familiar. These were the questions sent over in advance, questions about what we're doing to improve the health of our population, what's the status of our network adequacy, insights into substance abuse treatment programs, what we're doing in that space, what we're doing to address health equity, and our strategies for addressing rural healthcare access as well. So without further ado, I'll jump into member health outcomes. Honestly, I could probably spend a full day talking to you about the various programs we've deployed throughout the Commonwealth to address members' health. Obviously, you did not want a commercial or a full library or inventory of what those programs are. So we just selected a handful of the things that we see most frequently in our Medicaid population today. We have quite a few maternity patients in our membership, and we've got a variety of programs to meet those members where they are. I wanted to highlight just a handful of the programs. We have a program called Healthy First Steps. It encourages mothers both through education in terms of prenatal care, but also provides rewards for when they see their provider. We know how important prenatal care is throughout the duration of a pregnancy, and so they get a reward for every scheduled visit that they do attend, including postpartum visits. We also provide provider education, especially screening tools for providers to help uncover any mothers that might have underlying substance abuse disorder that needs to be addressed during the pregnancy as well. WellHop and Text for Baby are two programs that we have found to be quite successful. They're both app-based and web-based models. Again, provides a lot of education. WellHop in particular is a great cohort model. So mothers are connected with other mothers at the same gestational state of their pregnancy for that peer support. We also provide direct peer support for mothers that do have SUD and OUD treatments, which is fantastic for them to see a success story, see a mother on the other side that said, I was able to manage my substance use and have a healthy baby. And unfortunately, not all pregnancies go as planned. And so we've got case management, clinical resources that reach out for both mom and baby. And in particular, we've got a program called Neonatal Resource Services, and those support both mom and baby when there's a baby in the NICU. One of the other big categories that we see across our membership is diabetes. And this is a really challenging one, I will tell you. The most severe of our diabetes cases do get targeted case management. We also have a wealth of provider education, member education, rewards programs. We're launching telehealth and app-based services here as well, based on the heels of the success we've seen with maternity initiatives. I will tell you, I'm also spending a lot of time with our teams, understanding community partners that are doing great work around healthy food access and activity levels, which we know can help manage someone with type 2 diabetes especially, and hopefully prevent diabetes in the future. So more to come in that space. Another troubling pattern we've seen in our first 18 months or so operational here in the state is emergency room utilization. Our number one goal with this is to understand the why. Why is someone going to the ER when there might be a better place of care for them? Our number one objective is to make sure that they have a relationship with a primary care physician. So we will do outreach calls to understand, do they know who their PCP is? Do they have their contact information, and when is their next appointment? We also share ER utilization information back with that PCP so they know that their patient did visit the ER and that they have a point to outreach as well. So a lot of provider collaboration and member outreach in that space. We do, as many providers have member pharmacy lock-in programs. So if someone is drug seeking certain medications at an ER, we do have protocols put into place to alert our providers of that behavior and lock them in from getting those physicians. In some cases, there may be needs for urgent after-hours care. A PCP may not be available, have that after-hours phone line or after-hours office visits, and yet it doesn't necessarily require emergency room level care. So we make our members aware of both telehealth, doctor chat features, and in-home doctor visits as well. And for those where this becomes a routine pattern where they continue to present at the ER, oftentimes we will engage them in an ongoing case management effort as well. So they also have one of our nurses that they can call. But all of this, I would say, wraps around that really critical member-provider, patient-provider relationship. So everybody, I think, has shown a map that looks like this, right? Here's our network adequacy. I would tell you I am really proud of our network team. In 18 months with the state operational here, getting to 95% medical network access, 96% for behavioral health, 94% across dental. This has been a lot of work, individually meeting with providers and making those network agreements happen. We do have broad statewide access. All acute care hospitals in the state are contracted for medical services. As I mentioned in some of my opening remarks, we have a great agreement with Kentucky Primary Care Associates. There are challenges that I would recognize in specialties in certain geographies. There's a couple of things our team does to address those. We arrange for care with the next closest provider to that member. We can use single case agreements if someone is not in our network. And as has been thoroughly discussed, coming out of the COVID-19 pandemic, there are challenges in getting appointments. So while everyone may show you this map that shows 90 plus access availability for our network providers, there are times when someone struggles. I know I've personally struggled to get my kids into a pediatrician appointment within a month. So we have all had those moments. So what does that look like? I know is one of your questions. Our providers are contracted to meet certain requirements. 30 days for routine appointments, 48 hours for urgent for primary care. Behavioral health is 10 days for routine, 48 hours for urgent appointments, and 6 hours for emergencies. We do quarterly audits to ensure that that's the case. So we do essentially secret shoppers, call out, try to get an appointment with the provider. From a PCP perspective, we're seeing 99% compliance with our contractual obligations there, 90% on the behavioral health side. But in all of these cases, what happens when a member's trying to get an appointment and can't? They can call our member services line. We support members making those appointments for them. Our member services team is really adept at trying to not give the member more work to do, especially for Medicaid members. When I listen in on those member services calls and the supervisors sort of reviewing them and providing feedback to our frontline staff, one of the number one things they talk about is, did you leave the member with extra work to do when you hung up the phone? And if so, why? And this is one of those instances where we don't leave the member with that extra work to do. We will continue to call the provider's office, schedule the appointment, reach back out to the member and let them know that it's been done. Medicaid members don't need more work to do in that way in their lives. So with that, I want to turn it over to my colleague, Dr. Cook, who will provide you some overviews of what we do with substance abuse treatment.
Thank you, Krista. Good day, everyone. I'm Dr. Lisa Cook. Thank you. I have been the Behavioral Health Executive Director for United Care Community Plan of Kentucky, and I want to thank the Chairman Meredith, and our co-chair for the opportunity to present today, as well as all the committee members. I especially want to recognize Dr. Alvarado and other committee members for your passion around behavioral health, your commitment to making sure the citizens of the Commonwealth have good behavioral health services provided to them. And so with that, I appreciate the opportunity to share with you how we are supporting substance treatment programs, efficacy and effectiveness. And so what we look at is something we call a connection, a continuity, and a collaboration approach. And so that begins with us focusing on building a robust behavioral health network. It is our mission and our focus to make sure that we are addressing the complexities of substance use disorder, opioid use disorders, as well as co-occurring mental health and substance use conditions with having a robust provider network, which allows access for our members to address those issues and then foster those relationships for continuity of care, coordination of care, so that we can see favorable outcomes in their lives and in their recovery. And so we move from that engaging in building a robust network to accountability. So we're trying to continually build our network, and that's what we do every day to ensure that we have providers for accessibility of services. We also want to look at quality of services to ensure that the services that are being provided to our members are qualitative and they're working towards the outcomes that the members desire for their recovery. And so when we think about that, we move into what we call continuity of care. And so with that, our quality focus is continuous improvement around looking at data and data analytics, reviewing the data and data analytics. When we look at providers, we're looking at what's the best practices. Do we need to provide education around interventions and making sure that the providers are collaborating with us, ensuring that we'll get those appointments, as Kristen noted, for follow-up hospitalization and things such as that from a quality perspective. But also, we think about clinical. So our mission and our position is to support our members to have continuity of care and seamless transition of care through our utilization management process. And so we want to foster relationships with our providers through education and then working when a member does present for residential or acute care or outpatient services that we're looking for the least restrictive environment. We utilize ASAM clinical guidelines as we address the substance use care for our members. And then we have complex case management. Our focus here is making sure that we assess our members' needs through care management services. We coordinate with our members to support them for community tenure, as well as provide information if they need those areas of social determinants of health addressed. We provide referrals to make sure we connect with them and work on behalf of our members to ensure that those issues are addressed as much as we can. We have something in our model that's called a Recovery and Resiliency Program. And that program is specifically around addressing peer support. So we ensure that we address recovery and resiliency in every phase of our members' care because we understand that's an important part of their progress in recovery. So we look at continuity of care with clinical, we look at quality, but we also look at collaboration. And so our goal when we came into the market a year ago was to build relationships and partnerships with our providers. And so we do that through our care management program, building partnerships for our members, but also bridging those relationships with our providers as well in education and partnership. And so in education, how do we do that? I mentioned earlier our Recovery and Resiliency Manager. Her role is to go across the Commonwealth and identify areas where we see peer support needs to be actualized or people need to know more about that with the community agencies or our behavioral providers. She's going to educate around that space. And so she'll provide trainings free of charge to make sure that all of our providers that are working with our members and those agencies that are connected to our members understand the importance of peer support and have education around that. Equally, our utilization management teams, from the time we engage with our providers, we're fostering education on that process, ensuring that we are working together collaboratively while they're in care. Our provider relations team also provides education on a recurring meeting that they have with the providers across the state to make sure that there's any questions, how to navigate the space of working with United Healthcare, but they're actually giving education. And then our care management teams equally are providing education to the members. What are your benefits? We're going to talk about that. What are the programs that they can enroll in? We're going to share that with them, our care management teams as well. And then how do we support them in their recovery? So we're looking at education through all those different lenses. And then partnership. As I mentioned, we came into the market over a year ago, but one of the things we wanted to do as a strategy is understand the landscape of the behavioral providers in the Commonwealth. And so our case management team invites a behavioral provider or a community agency out every month to come in and share with us their services and what they're doing to help the members. And what does that do for us? That helps us build the relationship, but also allows a point of entry for our case management teams to be able to work with that agency or that provider group to make sure we're coordinating care for our members, which is what we want to do. Equally, we just launched in this year one of our programs, one of our clinical interventions in partnership with some of our residential facilities. It's called Reducing Admissions Through Collaborative Interventions. We call that program RACI. So what that really is that we look at their clinical leadership, their doctors, their clinicians, their peer support specialists, their case managers. We bring in our clinical team and we wrap around that member, and we see those members who have like more than 3 admissions or more in that facility. We wrap around that member. We try to strategize with that member to figure out interventions so they can have community stability. Again, our goal is to reduce the admissions that they're having, ensure that they're stable in the community. And then finally, as we look at partnering with our providers, behavioral providers, in this last year, the first year, we focused on collecting data. That was important for us to understand how our providers are providing services, and now we're able to use that data and talk about value-based payment arrangements. We're really excited about that because now we can be innovative and think about how we can look at quality outcomes and partnering with our providers in that work to make sure that we're building those programs for our members. And so thank you for the opportunity to share that with you, and I'll now turn it over to Greg Irby.
Thank you, Dr. Cook. Thank you to the chairs, to the committee. We're grateful for the opportunity to talk about our programs here. I'm Greg Irby. I'm the Chief Operating Officer for United Healthcare's Community Plan of Kentucky, and I'm happy to be here today. And I'm honored to speak about health equity. It's something that we care deeply about, and it's something that we're passionate about improving. I think as we start a conversation about health equity, it's important for us to acknowledge that we cannot positively impact health equity without understanding the unique needs experienced by each individual member. And so that's where we'll start our conversation today. For some members, their first entrance into healthcare is through our member services line. And so when they're connected to one of our agents, we're going to solve their immediate needs, we're going to address those, but then our agents are going to be prompted to ask a series of questions that assess the member's needs, both medical and non-medical. If a non-medical need or a contributor to health equity, a contributor to access is identified, our agent is going to connect them to one of our community resources. We use tools like our tool Find Help, which acts as a catalog of community partners and resources that are ready to help members. We will refer members to those community partners. We can receive information back from the community partners about a successful connection, but we're also going to follow up with the members to make sure that they receive the services that they need. Through this screening program, we've identified needs like food insecurity. That can be such a hardship for a family. We've identified those needs, and we've been able to successfully connect people to food banks and food pantries to make sure that they know where their next meal is coming from. One of our partnerships that we're really proud of and that we're excited about is our partnership with Goodwill. Over the last several months, we've sponsored Goodwill's Rise and Expungement classes and clinics. And through that, more than 1,100 participants have attended, and nearly 900 of those have received expungement services. What that means for these 900 people is that they're free to re-enter society. They're free to re-engage their community, to start contributing, to start receiving services and accessing services without that additional barrier. And so we're very proud of that. More than 900 are in the process right now of getting those services as well. Another element that we'll talk about in the health equity landscape is telehealth. We think of this as a really important function when it comes to addressing health equity. As the visual indicates here, we have consistent utilization of telehealth services across different geographies and across our quarters here. You'll see our top 3 regions specifically labeled here. You'll see Region 3, which covers the Louisville area, Region 5, which includes Frankfort and Lexington, and then Region 8, which includes many of the counties that were impacted by the recent flooding. So what we can see from this is that both rural and urban communities are benefiting from access to telehealth. Telehealth, it really does eliminate barriers to care, things like childcare, rigid work schedules, transportation. Those can often be an impediment to receiving the services that people need, but telehealth eliminates those barriers and supports health equity in that way. When we look at telehealth through a health equity lens, it really is a game changer because it changes the expectation for the member. Rather than expecting the patient to work through barriers to access care, it brings care to them. And that's something that can really help our population. As you can imagine, this type of access is dependent on broadband access, and we're happy to know that over 95% of the Commonwealth has access to broadband services because of investments that have been made in this Commonwealth. For members that don't have the appropriate technology or the appropriate mobile devices to access, we can refer them to one of our community partners who's ready to support and meet that gap as well. One of our studies that we found is that access to telehealth services increased behavioral health appointment compliance by 26%. And we believe that's because it eliminates the barriers to care. So again, I appreciate the time to talk about our program. I'll transition back to Krista, who will talk a little bit more about rural health care.
Microphone would be handy, right? In regards to rural health, I first want to walk you through our United Healthcare framework. We believe that healthcare is inherently local. So we use an approach that recognizes every community is different. We leverage data, which, as Dr. Cook articulated, we are about 18 months in, so we are excited to finally be at a point where we have a more robust data set. But we share those data insights with key stakeholders, members, providers, community partners, and together we convene groups to identify what are the key issues in this particular community and what are objectives that we can stack hands and work together. So we set measurable market-specific goals, and then we really try to address a holistic approach. So it might not be a one-size-fits-all thing. It might be data sharing. It might be value-based care agreements. It might be expanding or amplifying what a community is already doing in terms of building walking or biking paths. Again, our approach is to be out in the community, working in partnership with folks that are already doing great work there and figuring out what we can do, how we can contribute, and how we can amplify investments and good momentum already in place. But what does that look like in practice? I wanted to give you guys a couple of examples of community grants we have made. We invested about $1 million with the University of Kentucky, the dental program specifically, to reduce the rates of oral cancer and improve oral health care in Eastern Kentucky. The goal was to eradicate oral cancer in Eastern Kentucky is the name of the project. The funds have been used to raise public awareness of the symptoms of oral cancer, the links between oral cancer and heavy tobacco and alcohol use, and probably most important and critically is providing 1,000 oral cancer screenings at local health departments. The mortality rate for oral cancer is quite high. Over 57% of individuals do not survive after 5 years of diagnosis. And often this is because of delayed diagnosis. So getting those screenings in is really, really key. Another one that I would highlight is a $930,000 grant to Pathways to improve mental health care in Eastern Kentucky. This is putting in telehealth equipment and resources into Pathways facilities so that 3,000 children served across a 10-county service area could access more specialty behavioral health that they required and would otherwise not have access to. So I want to thank you for your time. I also want to make sure that all of you understand that we are here. We want to be good partners. We want to identify any issues that may come up, and we would welcome you to call any one of us at any time if you or one of your constituents are aware of any challenges. We want to make sure we're working through those with you in partnership. So thank you for your time today. We are really honored that you gave us the mic for a bit to talk about what United Healthcare is doing in the Commonwealth, and we would welcome your questions.
Thank you. Thank you for your presentation. I don't know if you and I talked about this before, but one of the reasons that we're asking our MCOs to make these presentations is the decade that we've been under managed care, we really haven't done a very good job in terms of moving the needle and improving the health of our population. I think when we started managed care, we were 47th in the nation. I think presently we're 44th. And we think that's predominantly because people have more access to insurance coverage that they had before because of the Affordable Care Act. So we're looking to significantly move up on that bar, improve the health population. And again, that's one of the reasons we have you here today. I would ask you, and it's a very broad question, but what do you see as the number one impediment to improving the health of the population of Kentucky?
Senator Meredith, it is a great question and one that I have been on the hunt to answer since arriving about 6 months ago. I don't know that it's a one-size-fits-all answer to that question. I think it is local community based in terms of what are the barriers for folks' health outcomes in each community. And what we've been actively doing is trying to get out into the community, whether it's meeting with community partners, with providers, to more understand what are today's barriers and what's our part in doing something about it. Is it access to care? Is it access to other determinants of health like food access, transportation, healthy spaces to exercise? Those things are things that you don't often see on a spreadsheet per se. But you need to see by being out in the community working with others. So we are still at it, learning more every day about each of the communities we're engaged with.
Well, thank you for that answer. Senator Carroll, you have the first question? Pass. Senator Alvarado, will you speak passionately on this one as well?
Yes. Actually, I was gonna comment, Mr. Chairman. Dr. Cook, are you a clinician?
I am.
Yeah, so I'll tell you, you have the most soothing clinical voice, honestly. We've heard a lot of testimony. If I ever have any mental health needs, I may give you a call. I mean, really, I'm not.
Leave your card, please.
Honestly, it's really soothing voice, and I admire that. That's it's important for providers to have it, particularly in behavioral health space. I appreciate the response on the local. We've been talking about how to revamp Medicaid. There's been some discussion. Some states do just that, is that they have a collaborative care organization rather than a managed care organization in which insurance companies work with local health departments to address very local issues and very local needs, which I think is of crucial importance because I think the response, there's generic responses we all know. Substance use disorder, mental health is a huge issue in the state. Tobacco use is still. Obesity rates and exercise issues are the biggest things that would probably have the biggest impacts on getting our state healthier. If we can get people to change behaviors in that regard, to improve their mobility, substance use continues to be a pariah really for the entire country and for our state in particular. But there might be particular nuances. So I'm encouraged to hear that you're trying to leverage data to get down to the very granular local level. I think that's needed. The other question I have, it's kind of a same topic when we talk about network adequacies. You're talking a little bit about the ER and why people use the ER more. As a primary care doc, people use it because it's open. If they're busy during the day or there's something else is going on, it's when things settle down and they can go. They have, someone's always got to see them there. Again, so if you try to contact somebody, it's not a convenient hour. Well, I'll go when it is convenient. I'm going because it's open. And that's frankly the reason why. And I've often, I think I've told you all, I've told every MCO group, someone needs to invest in an ER kiosk of some sort. You're talking about using that for behavioral health purposes, to put that in an emergency room to say, hey, if you have our insurance, and you can wait 4 or 5 hours to be seen for a cold or for a routine non-emergent situation in an ER. You have to sit and wait, or you can be seen right there, and someone can log in and they can be seen quickly, and out they go with treatment. I think would make a lot of sense. Would save a lot of money for everybody, for the system, and it would be a lot more expeditious for patients to get their care if they're going to go to the ER anyway to be seen. The other question is on the adequacy issue. I know you said the appointment availability is great. I was texting some folks I know. Do you base on the availability for that? Is it based on who the person wants to see or just having a provider to see? Because I think I often will ask, hey, okay, you have a huge clinic. It's owned by a hospital system. They've got lots of providers. Someone calls up with United Healthcare and Medicaid, and they want to be seen. How quickly can you get them in? They say, well, who do they want to see? If they want to see the doc, they're going to be waiting months to be seen for an initial appointment, even if it's non-emergent, months to be seen. If they're willing to see the nurse practitioner, we can get them in within the week, is what they're saying. So are you judging that based on who the person wants to see or just availability to any provider?
That's a really great question, and I am going to actually defer to Greg, our Chief Operating Officer, who's probably closer to those audits that we perform.
Sure, I appreciate that question. So we're looking at access in multiple ways. You saw the audit results that we're doing. Those audits are based on an audit of our network of providers. We're doing secret shopper calls into those offices, and we are acting just as if a patient would, calling into a specific provider, asking to see that provider that we found on our directory. And that's where we're trying to find out how long the appointment availability is or how long it would take to get to those appointments. So in the same way, we're just asking for an individual doctor. Other ways that we're looking at that, we are also listening to our calls from members. We're gaining that data by actually tapping into those calls and seeing where members are struggling. So we're trying to hear the voice of our members, and we're trying to do that proactively on our side.
And I'll tell you, I just know in what I do, obviously, a lot of folks will say, hey, they need to be seen by a GI doctor. Someone's really struggling, and they need a specialty appointment, and they can't find anybody. And this is not necessarily reflecting of you all. I think it's just of the system in general, what we're encountering now with shortages. And they think, well, Alvarado will know someone because he's kind of connected. And I'll call the guys, people that I know, the doctors that I know, and someone might be retired or someone is full and they're not taking any new patients. And the only person I could find is someone who's going to take 3 to 4 months to be seen for something that's probably a rather urgent matter. So that's why often I see these statistics from a lot of our presenters, and it's not often what I see on the ground. I mean, because I know a lot of folks. I struggle to find someone to see some of these folks quickly, and when they're asking me for help to help them do that. So I'd just be interested. I mean, the primary care situation might be quicker, and again, if it's just hey, I'm willing to see anybody, you probably can get in. If you want to see somebody specific, it's getting really tight out there right now. So I'll throw that out there just for review, but it's good that you guys are doing audits and kind of doing secret shopper calls, and that's good work.
Yeah, we
Thank you, Mr. Chairman.
Happy to follow up with you on that as well. It's not I would share it's not a Kentucky specific issue in terms of healthcare workforce. Our earlier presenters talked about that as well. We see it across most of the markets we serve today, which is why we try to continue to innovate on how do you expand the capacity of the workforce that we have today. Are things like telehealth a natural expander of the assets that we have, and we continue to invest in things like scholarships, especially for those that might be underrepresented in the healthcare workforce today. We've invested quite a bit in scholarships to support folks through schools. We think that's also a component of our health equity response. So thank you for your question, Chairman.
We have 2 more members of our committee that'd like to speak, and then we'll cut it off because we have another presentation. Senator Higdon, you're next in the queue.
Thank you, Mr. Chairman. And Krista, I think you've heard me say this before, but looking around the room, there was only a couple of us that were here in 2008 to 2011 when managed care was implemented in Kentucky. Representative Gooch and myself were here and heard the promises made by the administration and the MCOs that the managed care would improve patient outcomes, and the MCOs would make money by improved or healthier recipients, and I guess the promise was to be proactive rather than reactive, and again make sure that population was healthier. Somehow that went by the wayside, and we went through a period of time when MCOs primarily concentrated on provider reimbursements, and we had a lot of issues there, and I haven't heard any complaints on that recently, so hopefully we've moved past that. I guess my observation from where I sit, probably the number one issue we have with the Medicaid population is communicating with them. We talk about 95% of the state having access to the internet, but just not everybody is internet savvy or computer savvy. I found this out during the unemployment crisis. The phone calls that I got that people just simply could not negotiate the that process. They just couldn't do it, and so I think that's a big part of the issue. And I guess my question is, what are you doing anything to improve on the communication with your population?
Yeah, it is a challenge in terms of having good contact information for our members when we receive an assigned member from the state. When we identify a member that needs our support, one of the things that occurs is our clinical staff and our non-clinical staff does multiple outreach attempts, both telephonically, via mail, and then they get pretty scrappy, I would say. They will go into claims and look for, what pharmacies has the member been to, what physician offices has the member been to, and start calling those offices and asking if they have any contact information on the member. So it's a challenge, and one that our team takes on with full speed, uncovering any resource possible to get a hold of members that need our support. I would share the sentiment of the prior presenters as well. Oftentimes people don't think of a health insurance company or as a payer in the same capacity as providers, but I would say that I'm really honored for the folks that work on my team. They are mission driven. Our mission is to help people live healthier lives. And at those points of frustration, when they know a member needs help and they're having a hard time getting to them, I know they have to dig deep in that well of why am I doing this job, and really stay focused. So I appreciate the question.
Mr. Chairman, one final comment, and Krista, I think your numbers were better than this, but back in September last year, I saw a statistic that only 27% of the Medicaid population had received a COVID vaccination, and I don't believe in mandating that, but still 27%. When 1 in 3 Kentuckians receives Medicaid, that's over 1 million people that are unvaccinated. And I asked the question, how many of our folks that are in ICU are Medicaid unvaccinated Medicaid recipients? And I think that's kind of an indication, and hopefully your numbers have improved or are not in that category. But I do think that kind of, as a communication issue, that with better communication, a lot of that population would have probably decided to be vaccinated.
We've done a lot of work in this space. So yes, our numbers are better than that. We're almost to 50% of our membership is vaccinated. That does leave about 50%, a little bit more than that we would like to see vaccinated. We've taken a lot of approaches in terms of direct member incentives for providers when their patient is vaccinated. We've done a lot of listening sessions. Our Chief Medical Officer, Dr. Cantor, did a listening session with expectant mothers, trying to understand what their hesitancy was around vaccination. So we are trying to understand, for those folks that are still not vaccinated, what is the hesitation and what can we do to help them overcome that?
Thank you, and thank you, Mr. Chairman.
Last question / comment from Representative Moser, please.
Thank you, Mr. Chairman, and thank you so much for your presentation. This has been very helpful to understand all that you have going on. We're all here. I think everyone on this committee is here with the end goal of improving Kentuckians' health, and we look at all aspects. So on slide 4, you talk a lot about the initiatives that you're undertaking, and I mean, it all sounds amazing. As a former neonatal intensive care and flight nurse, I have worked directly with this population. I work a lot on substance use issues, mental health issues, and it's exciting. So last year we passed a bill to allow community health workers to be a Medicaid reimbursable service. How are you utilizing the community health workers at United Health?
Yeah, that's a great question. One I'm happy you asked. We do employ community health workers. They're a critical part of our outreach. And oftentimes we find them to be the most approachable at first for a member. They're not intimidated. They don't have a sort of white coat syndrome necessarily, and they can help identify those most critical cases that then really do need to connect with one of our nursing professionals. The other thing we have done, and I could have mentioned in our Rural Healthcare and Community Investments Fund, is we've worked with the UK Center for Excellence in Rural Health and sponsored CHW interns every summer out in Hazard. I got to spend time out there last month. We decided we didn't want to just write the check as a part of their internship, but we hosted as a part of that a professional development day. And so spent time with those students talking about professional brand building, put them through mock interviews, did resume reviews, and it was a really rewarding time for us. So we're excited and encouraged about community health workers in the state.
That's very exciting. And if I may just comment quickly, it would be interesting to see, as you increase this program, really how robustly the uptake is on individuals who are getting trained and certified as community health workers. And then I had one more, if I may, and I'll make it quick. There were some questions about barriers to utilization, and we talked about network adequacy. And you've been doing the audit for, you said, about 18 months and collecting data. Are you so we see on slide 6 the availability of access. What sorts of increases are you seeing in the actual utilization of services?
Yeah, unfortunately, I don't have that off the top of my head, but I'd be happy to follow up with you afterwards and make sure I get the data right.
Yeah, I mean, I think that's an interesting question. It's great to see that all of the resources are available, but if people, once again, back to the community health worker issue, if folks are not accessing care, there's, we're missing the boat here. Yeah. So I think if we could see what the utilization of services is in implementing some of these great programs, obviously you're looking at this because it's an expense that is unnecessary if it's not working. And I think it gets to the point of that some folks made about expanding Medicaid and not really seeing any movement in our health outcomes. So, if we can dig down a little bit more on some of this issue, that would be really helpful. And on the provider reimbursement, I am still hearing from providers that it's an issue. So I'm not picking on anyone. Yeah. I just, and I have conversations with the cabinet about this. So hopefully they're, having conversations with the involved parties. So. All right, thanks.
Thank you so much.
It's one that you and I talked about in our conference call, timely resolution of payment disputes. And sometimes those can run down to hundreds of thousands of dollars and may not mean a lot to a huge corporation, but if it's a smaller entity, it's their lifeline. And I hope you've looked into that and we have some resolution for that specific issue. But if not, I'm sure we'll talk more.
Yes, my understanding is it's resolved, but if you hear differently, I expect a phone call to tell me.
I appreciate that. And I'll just finish with, I think you've had a very nice presentation this morning, but I'll be quite candid with you. Out of 5 areas I asked you to address, I think you adequately addressed 4. And as Meatloaf said, 2 out of 3 ain't bad, so I guess maybe 4 out of 5 is not bad. But I really don't think you addressed question number 5, but that's something we can have additional discussion on in the future. But appreciate you being here this morning. Appreciate your testimony, and thank you. Look forward to working with you.
You as well.
Last item on our agenda is our update from the Kentucky Primary Care Association. I know those folks are here. If you will come forward. If you would, please make sure your mic green light is on, and then identify yourself for the record. After that, you're free to proceed.
Good morning. I'm Molly Lewis with the Kentucky Primary Care Association. I'm currently filling in as interim CEO, and I'm honored to be here. Thank you for inviting us, Senator Meredith and Representative Elliott. With me today is Dr. John Landis, who's the dental director at Health First of the Bluegrass in Lexington, and Tara Stanfield, who's the director of integration at Health First of the Bluegrass. And we brought them because I think that it helps for you all to understand what they're experiencing and the level of care that they're delivering. So, and thank you, Krista, for your kind remarks. We have a great partnership with the managed care organizations and with the Department for Medicaid Services, and it continues to improve. We know that it's a lot more than just Medicaid, but most all branches of the cabinet are on speed dial and have been very helpful. So our members are safety net providers of primary care, and I think that when you poll the general public about what primary care is, the definition may be a little bit different than what our members provide as safety net providers. So what they provide is a whole patient, community-based, consumer-informed, quality, cost-effective care. And they have to because of the way that they're paid and the way that they must engage their patients in order to move the needle and make a difference. Primary care that they're the gateway to healthcare for about 1 million Kentuckians. So it's not all Kentuckians access this type of primary care, but it is a significant population. And we know about health that about 90% of it is social determinants of health, and really understanding what I like to think about as life and what patients need in order to improve their health. One of the ways that we serve our members is through the opportunity to perform a supported provider network. So when Krista mentioned network adequacy, part of it is the Primary Care Association's network, because we have members that includes over 30 community health centers, which you all might know of as federally qualified health centers or lookalikes, and over 60 rural health clinics, which are also in underserved areas and have to deliver a comprehensive integrated healthcare approach. We're in over 300 schools and about 40 public school districts. So it is in the nooks and crannies of our communities. Evidence shows that patients who access primary care have better health and lower healthcare costs. So the point is, how do we get patients in the door and taken care of? How do we avoid unnecessary visits to the emergency room? How do patients know who to call and how to get what they need? We believe that the value of care that our members provide is a significant testament to the benefits of this model of care that's coordinated, integrated, and comprehensive. And so I'd like to turn it over to Dr. Landis and Tara to tell you all a little bit about a really impressive program that they have at their federally qualified health center in the Lexington area that includes community health workers, doctors, dentists, healthcare providers, nurse assistants, the whole gamut, and how they work together to deliver effective care.
Thank you. And thank you to the committee for having us today. My name is Tara Stanfield. We're Health First Bluegrass in Lexington. We're on target this year to serve close to 23,000 patients. So we're getting back to pre-pandemic time. We have 16 different locations in Lexington. Part of our model is that we want to make sure we're providing the right service to our patient at also the right time and the right place. So we're real strategic about where we put those locations. We have 2 that are embedded into homeless shelters in town, and we have 10 full primary care clinics that are embedded into Fayette County Public Schools in underserved areas. Each of those clinics, the homeless sites and the school-based clinics, all have a full-time nurse practitioner, have a full-time therapist, a behavioral health therapist. We rotate dental and psychiatry through those clinics as well. And they're just really super cool when you get to go see them. Most are in elementary school. We opened our first middle school a couple years ago, and yesterday opened our first high school. So send us good energy. We're getting into the high school waters, and we're excited about it. Like Molly said, we provide several services. We have women's health, we have adult and pediatric primary care, we have dental, we have a couple of pharmacies that are at our locations. We have behavioral health services, including psychiatry, and we have a ton of services aimed at reducing barriers to care. So you hear people talk about social determinants of health all the time. At the front of that are our community health workers. We have a fantastic team that pretty much work miracles on the daily for patients. And we're real excited about our model. I know you guys have a special interest in hearing more about dental, so we wanted to really highlight that service at our clinic today. And then wanted to just tell you a couple of examples of how it works, because I just think, like my parents still don't know what I do. Like when they ask me what my job is, they've had a hard time the whole time because I'm a therapist too, so that was confusing. But this really confuses people. And when I interview people and I try to explain them about the job, when I interview a therapist and say, look, I'm going to place you on a primary care unit working with at least 4 or 5 doctors, and you're their partner, and if anything outside of their scope comes up, it's for you. And they'll say, well, that's not how normal behavioral health work works. Like usually somebody schedules an appointment and has somebody telling them they need to schedule the appointment. It's not just somebody that just walks in the door for a sore throat and starts to cry because they're deeply depressed and they've not talked to anybody but their primary care doctor for 5 years. And the primary care doctor is able to say, uh-oh, let me go out here and get somebody that specializes in this. And then that intervention is going to happen right there on the medical side with the medical team. That's just not the way people are used to working in my line of work. So even when I try to explain it to them, it's not until after somebody's been there 3 or 4 months they say, oh, now I get how this all works and how these people all work together. So we'll tell you some examples of that, and Dr. Landis is going to share a little bit about our dental program.
Thank you, Tara, and thank you, Mr. Chairman, for the opportunity to speak here today. My name is John Landis. I am the Chief Dental Officer at Health First Bluegrass. It's been a privilege of mine. My background includes 25 years as a dental Medicaid provider here in Kentucky. 12 of those years were in Harlan County with a private practice. So in eastern Kentucky, I definitely have that rural Kentucky experience. And then the last 12 years has been in Fayette County with Health First Bluegrass. So the majority of the patients that have been served over those 25 years have been patients with Medicaid. And Mr. Chairman, as you know, Kentucky does have a good history with oral health resources. Kentucky was the first state in the nation to have fluoride in every county in the state. So we do know that there's resources available with oral health. In line with some of the conversation today, the common denominator in regards to patient access with oral health, as with other disciplines, is with establishing the relationship with our patients. And Senator Alvarado had a great question about the continuity of care with the same provider. That is difficult. How we manage that, whether it's rural, whether it's urban, whether it's the private sector, whether it's the public sector, we all strive to do that. The challenges from COVID, whether it's staff being out due to employee health reasons, whether it's the challenges of hiring, whether it's a position that is open longer than you prefer, we all want the same goal, which is what's best for our patients. I just want to give you a quick snapshot of what we're seeing with our patients in regards to oral health. Health First Bluegrass did not close during the pandemic. We know that elective services were discontinued for some time, so treatment plans were kind of kicked down the road. So as a result of that, what we're seeing now, and we're playing catch up, is that there has been an increase in urgent needs, an increase in walk-in patients, an increase in extractions, because some of those treatment plans that may have been restorative care may have turned into extractions. What we're seeing in our pediatric population is of our new pediatric patients is 75% of our children have unmet oral health needs. As high as 10% of our children may have urgent needs with a definition of pain and infection. So what we do, we're fortunate to have resources to be able to follow up, make sure these patients don't follow through the crack, that we work with the patients, we work with the schools to follow up, to assist with transportation, to assist with language barriers, to make sure that we complete those treatment plans. We all talk about outcomes. We all talk about access. In the dental world, it's completing a treatment plan is the main goal. In regards to urgent care, what we're tracking is how many of those patients that are coming in as a walk-in. And we dedicate a team just to those walk-in urgent needs. How many of those patients have the ability to come back and establish not just a dental home, but a full healthcare home? In regards to workforce, many community health centers, including Health First Bluegrass, both dentists and hygienists are eligible to have their student loans repaid, and that's through the National Health Service Corps. So we know that with the rise in tuition costs, that's a great value for our providers. So that is a benefit that is helpful in our recruitment. The integrated care model that Tara was discussing at Health First allows for a team-based approach to identify barriers and behavioral health needs, and these otherwise may not have been caught. So through innovation, through ideas, we want to share a couple of success stories that we have seen. One is dental hygienists communicate with our women's health team, educating expectant mothers, preventing baby bottle tooth decay, building trust early, and reducing future costs, improving the overall health with a team-based approach. We did pilot a community health worker embedded within a dental team. So what did that look like? One example is that we have a teenager that was present for a dental visit, and it was identified that teenager had suicidal thoughts, had symptoms of depression, and we were able to provide the resources needed for this patient, and that originated from a dental visit. So through collaboration, we were able to assist our patients. Our dentist may identify patients whose oral health has rapid decline, and we know both in the urban and rural settings that this could be a sign of substance use. So once again, it takes a village, right? It takes a team. It takes a community. And that's what community health centers are all about. And Tara's going to give you a couple more stories.
The behavioral health people love working with the dental team. Several times the dentists have identified patients and sent them our way, or when we've had our team co-located with them in ways that I would have never thought a patient would make it to you. They had an example post-hardcore pandemic times. I'm not sure what space we're in at any time. We had an example where a young person, a college kid, came in to the dentist. Dentist goes and finds a community health worker and says, something's not right. This kid, I've seen this kid since they were young. They've had immaculate teeth. They take care of their teeth. And this kid's got 6 cavities. That something's not going right. I don't really know what to do. That's not what I do so much. Community health worker goes, starts talking to the kid. Kid says, you know, it's not right. I was seeing a therapist. I had a psychiatrist. The therapist got me with a psychiatrist, and my therapist moved. And I just couldn't stand to tell my story to a new person. I just couldn't do it. And so I stopped. And then I felt bad every time I'd go to the psychiatrist, because the psychiatrist would ask, well, how's it going with your therapist? And that's how depression works. Like, it starts and then it piles on, it piles on, it piles on. And so via a dentist saying something's not right, our team's able to say, hey, let me walk you downstairs where we have a whole bunch of therapists and psychiatrists, and let's get you hooked up with them. And it worked out. And so we got that kid wrapped in. The hardest challenge for me in thinking about coming here today and talking to you guys about our model was like, what are good examples, because there's so many, it's all day long, it's every day that kind of thing is happening, where we're able to identify people who just wouldn't go, especially on the behavioral health side. There's so many things that would keep somebody from going, whether it's you don't understand where to go, whether it's you're scared what they might tell you when you go, or stigma or cost or whatever. But people go to primary care, and so when they show up there and they say whatever, and we ask the right questions and we screen our patients pretty heavy, and you're able to get that service right then and there, it makes a huge difference. And the amount of information we have via ER reports or all of those kind of things, it's just a whole different kind of ball game in being able to treat our patients. But the story that stood out to me a lot is we had a family, the majority of the family were our patients, adults and kids. We had a family a little while back that had a terrible car accident. The youngest child passed. Older brother was sitting next to her and had some injuries but survived. We get the ER report. The primary care team gets the ER report. They schedule a follow-up because everybody sustained some injuries. The kid comes in, seeing the primary care doctor, and really turns into probably, in all my years of doing behavioral health work, maybe the most just acute pain, emotional pain I've ever seen in this kid's just feeling of guilt, big brother guilt, that this has happened for their family. And the primary care pediatrician immediately reaches out to our behavioral health consultant, who's standing right in the pod, just waiting. Behavioral health consultant gets involved with the kid and starts working with them pretty heavily. Because we know with trauma, those first couple of days and first couple of weeks after a traumatic event you will naturally set your own way of explaining what happened. And young people, anybody, can set that real wrong. You can get all kinds of ideas, whether it be guilt or should have been me or all those kind of things, and then work through that the rest of your life. And so the fact that within a couple of days after this event happened, we're able to start that with a professional who's trained in trauma, helping that little boy. But he kept on having problems, and he mostly was having problems at school. He would kind of do okay when he got home, and meanwhile, the family's falling apart. Just as I'm a parent, I can only imagine what that would be like for the parents trying to support the children. And he kept just exploding at school, and to the point they're afraid he's going to start getting in trouble. The school was working with him and being good, and the therapist said, "What's the problem?" And he said, "I just feel so closed in when I'm at school. Like, I just sit in the classroom and I feel so closed in." And he said, "What if I called the school and asked them if we can send the community health worker who was used to the family and working with them a lot of that time, and send her out? And maybe sometimes when you're feeling that way, she can just walk you around the track or walk you up and down the halls or whatever." And the kid is a middle schooler, so I kind of thought, he's not going to do that. He says, "Yes, anything, yes." So she starts doing it a couple times a week in the beginning, the community health worker. The conversations she would tell me that she and this little boy were having were amazing. And then it bridged to a week at a time, and then she'd only go every couple of weeks. But I just think this, from a primary care, you just don't expect that when you go to primary care, to be able to have those kind of services wrapped around. And I couldn't be more proud of what we've done and where I think we can go, and just of all the people that we get to help. So thank you for letting us talk to you about it a little bit today. And we'd love to take any questions, or if you ever have questions in the future about it. I'm sold. You can tell I've drank the Kool-Aid of integrated care. But in the future, if you have questions or anything, we would love to hear them.
Thank you. Excellent presentation, and I think you just reinforced the beliefs we've always had, that primary care is the foundation should be the foundation of healthcare. And I'm always bewildered that, you know, it's the foundation. Well care is a whole lot cheaper than sick care, but we don't invest the resources to address those things. And I noticed from your handout, one thing that really stuck out for me was that we have 94% of our counties have a primary care shortage. How much is that costing our Commonwealth because of that shortage? And I don't think we ever asked the basic question is why? Now, I know there's a shortage of personnel everywhere, and in primary care it's been there for decades, but it doesn't answer the primary question is why can't we recruit healthcare professionals to rural communities?
Senator Meredith, that's a great question, and I think that it loops back to some of the questions that we've heard you ask before in the past about having cost-effective, forward-thinking, proactive approaches to avoid really expensive end game. And one of the ways that we're working on it is not just workforce development, but workforce retention. We're about to start a community health center learning center in northeastern Kentucky, where there are opportunities for residency programs, because we've learned that grow your own is a really good model, and that people who are invested in communities and are educated and committed to their neighbors are really good providers. And so we need to provide ways to support that growth in workforce. We will not have enough primary care providers to meet the need or the growing need unless we start thinking about the training and the opportunities to enhance this workforce. With that being said, I think that the primary care model, what has previously been described before managed care and before it became the neighborhood approach of healthcare became more integrated and more comprehensive, the reimbursement requires a face-to-face with a doctor, nurse practitioner, or PA. But what we've learned is that in order to have an integrated, comprehensive care, a lot of times there's more diversity in who can meet those needs, and having appropriate planned care that involves community health workers and which obviously cost a lot less money than doctors and nurses, or to have peer support specialists, people who are actually in recovery helping somebody sustain their own recovery. There are other ways that it doesn't have to be a doctor and nurse all the time, because that's asking too much and it creates burnout, and it's really hard to retain that type of workforce, and it's not really the most cost effective or the most appropriate. So I think that it's great that we're able to think outside of the box. There's also some types of care that can be done at the school, or can be done over the phone, or by a visit, or visiting the Area Development District Senior Center. There are different ways to meet patients where they are, so that the load doesn't always have to be carried by physicians.
Agreed. Representative Mosier, you have a question, comment?
Yes, thank you, Mr. Chairman, and thank you very much for your presentation. Thank you so much for your work. I think I've been sold on the integrated care model for I don't even know how many years now. I mean, it makes complete sense. And when I was the director of drug control policy and working on substance use disorders, we always said, to destigmatize substance use disorders, we need treatment to be just a part of primary care. So I'm interested in a lot of this. But what are there challenges in providing this integrated care in billing? Do you have, oftentimes reimbursements are really compartmentalized, and I'm wondering about the funding model and what your challenges are.
I would say from the integrated care side, the biggest challenge that stands out, and I'm sure our CFO would prefer to answer the question than let me, but I would think would be the 2 visits on the same day problem that we run into. So that whole model where the therapist is just kind of there ready, and there's always plenty to do. Most of the time it's whoever got to that patient first. So that's a challenge for us for sure.
Right, and that's problematic because if an individual comes in for a dental issue and a mental health or behavioral health issue is identified, you can't even treat them. So, or you can, you're not going to get reimbursed.
Right.
But, I mean, that is a big problem. I don't know if that's, I think it's probably a federal issue and, with CPT codes and all that goes into the reimbursement model. But certainly there's something that we can do to work on that. So I'd love to kind of dig down on that issue too.
Thank you. We would love to come and work with you on that. We actually have some good ideas. There are also opportunities for us to show that sometimes it does really work. If you were left to our own devices, we have to build relationships, and we've been able to work out some things with our managed care organization partners, for example, where chronic care management or transitional care management or types of things that don't require a face-to-face visit, that they can still be reimbursed in a different way, and that patients can be kept out of readmissions. So there is some innovation, and we think we found some flexibility, but we have some other ideas too. Also with the treatment plan for oral health, being able to treat more than one quadrant every month, those types of things would be
Right.
helpful.
Okay. All right. Yeah, let's talk. Thank you.
Senator Alvarado, you have the last question comment on this subject.
Thank you, sir. So this is team-based care, which is what, I know the doctors have been talking about this for at least since I've been practicing medicine, almost 27 years or so, which is great. It's a dream for most docs, and they want to do this. We used to be able to do these things in the office, where I actually had a counselor in the office because I found that we had to refer so many people out. We kept it. The difficult part of that is, like you just stated, is if someone comes in for a well visit, they're coming in for that code. I have to address a bunch of stuff now for government and for insurance, and I've got to fill it out. If they say, doc, while I'm here, can you look at my knee? Or, hey, I've got a tooth or some other issue. The response now, it used to say, yeah, sure, of course, let me address it. I put a modifier. You get reimbursed a little bit extra for doing that extra acute visit and doing the well visit at the same time. Now I got to say, yeah, sorry, let me do the well visit. Make an appointment for next week so I can look at you for your knee too. Why? Because government needs to have that data collection we heard about earlier. They got to collect the data, see what's an acute visit, what's a well visit, and they have to separate all that stuff, and it's become nonsense. And a lot of it's federal. That's coming down. This is a much, give somebody a global fee and say, look, address all these things at once. People can take off of work once to come in for everything at that same time instead of having to take off multiple visits. It's kind of a ridiculous. So I commend you. This is great. We've been talking about this a long time. Talking about residency programs. The United people are still in the room. Please hear that. I know we talk about funding medical student slots. I mean, nursing student is important, but we need graduate medical education, which is residency positions. 80%, I think 80% of the physicians will practice within an 80-mile radius of where they do their residency. If I'm a med student and I go to Oregon and do my residency there, odds are I'm going to stay in Oregon. I'm not coming back to Kentucky. So we need residency positions of all types, but particularly for psychiatry, for primary care. Two other things I'm going to ask you really quickly. You mentioned that you guys have your own psychiatrists. That perks my interest. We have a major shortage. I'm curious, you don't have to answer it yet, how many psychiatrists you guys employ within your system. And secondly, I'm looking at your handout, and it's a very important topic for me on the workforce development. And on the bottom under the financial perks, malpractice benefits through the Federal Tort Claims Act program. Maybe you could expound on why that's important. Has that helped you attract other providers? Because I've been claiming we have a hard time getting docs that come into states where we don't have that in place. And the fact that that's a perk that you guys identify, maybe you could expand on how many psychiatrists and then on that issue as well.
Yeah, so your question about the psychiatrist, how many do y'all have?
We have one full-time adult psychiatrist and one very part-time child psychiatrist. I will say that the psychiatry problem is a huge problem for us. We have several psychiatric nurse practitioners that work alongside of them, and the way that we have made it work with seeing as many patients as we have is oftentimes once our psych team can stabilize a patient, we can pass that care back down to primary care, and they're comfortable with some patients, some never. Some need to be with a psychiatrist, but some are okay. But we're trying to hire for a child psychiatrist right now, and it's over. It feels over. I'm not throwing in the towel, but it's hard.
There are 59 in the entire state, is my understanding. So if
Yes.
you got a half of one, that's pretty good.
I know, yeah.
Okay, so Federal Tort Claims Act is a beautiful structure. When it works, it creates a sense of immunity for a public workforce of healthcare providers, and it also helps, especially as we know, like OBGYNs and pediatricians, just the liability can be cost prohibitive. But it is limited to our community health centers, which are the federally qualified health centers that actually receive a 330 grant. So we have 26 of those in here in Kentucky that benefit from it. And one thing that we have been talking a lot about, especially during the flood response, is our members are very collegial, and our community health centers, federally qualified health centers in areas that have not been impacted, have been desperate to assist those that are impacted. But the FTCA does not travel. The portability is a problem. But that's a federal issue. I know that you have lots of, we're talking to them, but I do think that maybe in times of emergency, some of the Good Samaritan rules that are currently in place could maybe be expanded so that we do have a more portable workforce of individuals who are trained in this delivery model. And as we know from COVID, they're essential providers that we don't miss work. These providers, not me personally, but the providers that we support, they don't close down, roofs blow off, and the doors are still open, and it might be care in the parking lot. But as an essential provider and as part of our national system of healthcare, FTCA is a benefit, but it's not available to everybody.
And part of that benefit is that part of what that act has is that if you have an issue or a claim you're going to file against a provider, it goes to the federal court system, which has a much easier dismissive. I mean, if you get a frivolous lawsuit before that, a judge can easily just throw it out. In Kentucky, we don't do that. And we've tried to, for us to implement that, it's going to require constitutional amendments, because every time we try to do some of the things that you recommend about saying, hey, grant expanded immunity, someone's going to sue the constitutionality, and our Supreme Court says it's totally unconstitutional. So we have to change that to give ourselves the authority to do that and implement some of the good things that act has to provide for providers here in Kentucky, if we can get it done. So I commend you. I'm glad that you put it on there. It's very important that we consider to keep that front and center, because that's, again, it's an important thing. And again, if it limits people from volunteering to help people in a situation like we have right now for fear of liability, that shows you what is true across the board and how people practice medicine. Thank you.
Thank you.
Thank you for your presentation. Very enlightening, very educational. Always welcome you folks here and look forward to our continued relationship and working with you.
We appreciate you. Thank you.
Great presentations today. Good meeting. Our next one is, for your calendar, Thursday, September 15th at 10 o'clock a.m. No further business. We will stand adjourned. Thank you.
Good job.